You know, I have been working with the clinician people. What I mean by that is that we use clinician in our clinics, I'll tell you that. And we have since 2011. So I've known Jerry back when Jerry was doing the individual training for clinics. So I've enjoyed watching how clinician is growing in its mission. And to the extent that you label an engagement process with a group of people empowered, you know, part of that mission to empower somebody is a real powerful contribution, especially to us. And raise your hand if you're concerned about the future of healthcare. Yeah, right. And it's kind of funny, and I had this conversation with my wife earlier, because we're right now renewing our health insurance plan for our company. We've got 9 clinics in Tucson, and we're right, you know, discerning out who we're going to choose. And this idea of concerned about healthcare versus concern about the business of providing healthcare. It's really 2 different things. And I'm gonna get a chance to pull us out of the talking about the business, although this is so relevant. I'm gonna put us right back into the clinical care thing, which a lot of us, at least at the very start, is where we got our juice. And I still think we get our juice here because you know, probably if you had to take a look at what fires up your staff or what keeps you motivated, is how it is that you're changing lives. I mean, it happens on a daily basis that we're touching lives. So that can get lost. So I want to talk about it. And tell me if resistant patience is a part of your experience as a physical therapist. Raise your hand. Yes, the resistant patient. I have a clicker. Okay. So I've given this talk in a number of different ways, and this idea of reining in the patient, like the patient's out of control. So what you need to do is you need to lasso them and just pull them back in so that you can get them to do what really they need to do to be healthier. Because our job, in part, is to get them moving. We are the movement specialists, but you know what? There's only so much we can do to somebody. At some point, it's a process of them being as much a part of their health as we are a part of their health. Now, how do you frame up that experience? And most importantly, how do you minimize the frustration of dealing with patients that you're just like, can I really deal with that? So I'm going to try to do this. I'm going to do this in the context of taking an excerpt of a course. And this is a course that I teach. It's a 2-day course. And I'm pulling content out of a 2-day course into an hour. And if you have watched out of the back of your head Jim with this little sign, he is not kidding around about the time you have left when you're speaking. So it's serious. I mean, and he will walk towards you. He's got body language that tells you that this is serious. So I'm going to try to stay on topic. And we'll deviate, and we'll try to get through all the stuff. If we don't get through all the slides, we can talk about them over drinks, which is often more informative. So, introductions. Thank you, Jim, for the introduction. I'll just fill in the gaps. I am a physical therapist and athletic trainer. I'm the owner and director of Proactive Physical Therapy. The International Academy, the IAOM, is a continuing education company. We teach continuing education in the United States, in Latin America, and in Europe. I was the head athletic trainer and the director of sports medicine for the University of Arizona. I studied biomechanics and motor control, went to NAU, and as Jim mentioned, I teach in the fellowship programs. Probably the most fun of it is teaching in the integrative medicine program, which is the world famous Andy Weil, Dr. Weil thing in Tucson. And Tucson's kind of a hub for integrative medicine, which is cool. And I teach manual medicine to the residents and fellows. And the whole concept of manual medicine. What is manual medicine? Which was previously taught by a DO. So I think it's really cool that a physical therapist gets a slot in there. Kind of a badass, really, if you think about it. I mean, wow. And you're right, I've been around forever now. But let me tell you a little bit more. So I grew up in Yuma, Arizona, which is in the corner of Mexico, California, in Arizona. I still drive a 1969 VW Beetle. It's the same car that I drove when I was in high school. And my son's driving it now. So it's pretty cool. I race bicycles. I have a Cannondale CAD 9, which is an old frame, but I got a great deal on it. But I got some Zip 404 wheels, and Wells and I talked about this. So I can go fast if I pedal fast. It just seems. Music. We love music. My wife is a music teacher. So we have a band, After 7. It's the name of the band, After7Tucson.com. You can look it up. Married for 22 years to Chris. Daughter, Natalie, who's 19. And Timber, my son, is 17. Which is kind of cool, right? Because Timber, what's my last name? Really? Who did that? Let's go even deeper. Faith, Christian. My wife, Chris, has multiple sclerosis for now 20 years. One of my kids has a history of drug addiction. Struggle with balance, life balance. I have a personal mission to change healthcare. So what happened? What happened? What I did, I started to introduce myself. What did you experience over a process of me telling a story about me? Yeah. So I started telling you some things. And you, yeah, okay, good. And then all of a sudden, I started telling you more. Oh, I saw some smiles. And then I started telling you more, and you could hear a pin drop. It was that quiet. Anybody getting comfortable? Nobody got a little uncomfortable? Like, why is he telling us this stuff? Chances are there was probably some discomfort. That usually when we start to get a little closer to somebody, there's a level of discomfort that we have difficulty managing. Because there's a certain level of information exchange that, how would you say it? It's a certain level of vulnerability. It's a certain level of, I'm going to use the word intimacy. And it's a fascinating process when you take a look at what happens between the patient and the provider. Between the patient and the provider is a rapid exchange of how would I say this? Some level of intimacy. And it's not a small thing. You all kind of felt what it felt like. But when you see me and I see you, something really important happens. So hold that thought. And I want you to recognize that there are some levels of seeing that allow us to begin to understand how and to what degree we're actually connecting with our patients. How are we connecting? So are you seeing the injured body part like a medical diagnosis? Because usually you see the chart, you see that patient portal, which is right in your face. You know, you can't get away from it. It's so awesome. Then there's the function of the patient in the clinic. That's something you're paying attention to. I know we're all good at that. Do we see the function of the patient in his or her environment? In other words, can we extrapolate what we are seeing from what we're seeing in the clinic? Can we extrapolate that? Can we use our imaginary powers to see how they're functioning at home or in their environments? Can we see the feelings of the patient, their emotional state? Can we see their fear? Can we see their anxiety? Can we see the other barriers that get in the way or could get in the way of what we need to accomplish in the clinic? How about his or her conscious story? Big deal. Can we see their story? How much time do we have to get their story? How about his or her unconscious story? Do you think that each of your patients has a story? This is a fascinating topic. I could do an entire 3 hours on healing, the entire topic of what healing is. And the medical literature bears all this out. It's really the ability to contextualize your events, of who you are and what you're doing, what's happening to you. So, our ability to see at the proper level will allow us to engage at a different level. And oftentimes, it's the level that allows that engagement and relationship for which we want to build outcomes, because it's a big story. Relationship. Now, when you come to an event like this, and I'm watching it happen, I'm watching the colleagues here at Clinician working to build relationship with their clients. They want a partnership. They want to work with, I'm going to say us, I'm one of those guys, in a process of trying to battle all of the headwinds that are coming as we ride our bikes down the road. Relationship, and you can look in the context of your own lives, the most rewarding parts, and our keynote speaker earlier spoke to it, the relationship is what most people desire it, but the millennials are really hot on this. They really want a team, a relationship, because you know what it feels like to belong. So what do patients want? Patients expect caregivers to show that they actually care by their warmth, interest, focused attention, and they want providers to understand their whole person, emotional needs and life issues and treatment that enhances a continued relationship between the patient and the doctor. Yeah, that's what patients want. We know that. Why is this difficult? Is this difficult to do exactly what patients want? Because by the whole way, our entire medical system is not good at doing this, obviously. So why is this difficult? What prevents this connection? Connection requires serious energy. Do you know what that means? Serious energy? Can I do a little demonstration? Can we do this? We did this earlier. Someone stood up. I'm only going to get, I know I'm going to run out of time here, but I'm going to do this anyway. I would like to run a little experiment. I want you to steal the energy. So you're going to get someone that you're going to partner with. So you have someone next to you, perhaps. If not, go find someone. And what I'd like you to do is I want you to look at them, and I want you to look at them and notice the color of their eyes. And then I want you to say, I see you. You guys ready? Okay. Okay, I hear a lot more than. Okay. Good. Did you do it? Yeah. How many? Who kept a straight face? Nobody. Now, how difficult was that? It's not that easy, is it? Now, and I'm a therapist too. I'm in the clinic. I'm seeing patients. And, after a while, you just get this compassion fatigue at some point. This ability to connect with people on a regular basis is difficult. So do you know what happens after a period of time? We dumb it down. We can't possibly manage it all. So our nervous systems, you felt the anxiety. And usually, how do we manage the anxiety? This is funny. I see you. Because we got to lighten it up, right? It's a little too hard. Because that's how we're built. Our nervous systems are built this way. Until you're really into a different level of relationship, which is fascinating because the relationship between a provider and a patient is one of those levels of relationship that can be very, very serious, very important. It requires an ability to gauge that part of you that connects to the other. And there's a lot of neuroscience behind this. I'm into the neuroscience of what part of that nervous system of mine connects to other people. There's the mirror neuron system, there's interactions with the limbic system, there's all the centers that, it just keeps going. Requires some level of feeling the other story, some ability to feel the other story. This is empathy. Can you feel enough of their story, but not too much of their story? That's another key thing. Because if you feel too much of their story, what happens? Ever felt too much of someone's story? What happens to you? Huh? You do, you step on the shape, but what happens? What do you feel like? I mean, you're like, oh, how do I step out of that? Cleanse yourself of that. How do you get free from that? Because it's a process. And an inability to access the proper level of feeling. So in and out is an important process. But the in part is how you connect to people. Connecting to people is very, very, very important in the context of getting an outcome. So, providers are not taught the skills to manage their own story when engaging with patients. This is one of the biggest issues, especially in the physicians and in the medical doctors, is empathy is lacking because they just don't know how to manage the stories. It's very difficult. It's hard. Our jobs are hard. I mean, it's hard to manage the billing collection side of things too, but it's difficult to be with people at the level that they need to be with. You know what I'm saying? Be with. So a training program helped to align So we developed a training program to align an organization, build the skill sets, evidence-based clinical frame, and how to coach providers to maximize connection and decrease failure with connection and avoid burnout. And those are the specifics of the course. Really, we want to help people engage at a different level, how to see at a different level, and inspire a healing response. The story of this course is born out of this idea of how can we get better outcomes. Here's my mates in the academic side. How can we study outcomes? And if you take a look at evidence-based anything, the conundrum is the patient doesn't often follow the rules. If they don't follow the rules, you can't apply the rules. You've got to make it up as you go. And you could start with a rule, but what happens if they don't fit the rules? And Paul and I were just talking about this, the CJR. How are we going to do this? Because some people don't fit the box. And what we need to do is explain the outliers. So typical outcomes research is this. You have the patient, you have a treatment, you do a technique, and in a biomedical approach to things, you have an outcome. It would be really easy if it was just about the technique, right? Because, we're technique specialists. We do stuff to people with manual therapists. We're good at that. However, the outcome is really, really framed up in this whole idea that there's a whole person behind there, and that person is complex. That means the beliefs that you hold, your environment that you're in, the alliance that you create with the patient, the neuroscience behind what happens in the brain with your treatments, and the patient's beliefs. Big, big deal. So there's really a major shift. We're talking about all these corrections. The business models are shifting, demand for values and outcomes, declining reimbursements. People are shopping for value. How many of your patients now are actually shopping for you? Yes, they're shopping because, and frankly, I want them to. I think we should be one of the first choices. And we'd hope that the system would mandate that they see us, like the employer-driven process that Rick was talking about. But we would love for them to choose us because we're the first choice. And the worldviews. If you have a biomedical worldview, you're defining the problem as anatomy only, sees cure as a goal, disease is bad, and mortality is failure, which is what we're really trying to do is shift to a biopsychosocial model of care. And you've seen this already. This used to be really, really new, and those of you who are paying really close attention, the research is coming out. There's not a journal article, there's not a journal that gets published every month without something relevant and relative to the biopsychosocial model of care. And it just keeps coming. So you'll see that our ability to shift towards to being not just mindful, but skilled in this a psychosocial environment is going to be critical to the success. And it just keeps going. Well, interesting to me, and I think you noticed that I went to PT school, then I went back to graduate school because I was interested in neuroscience. I wanted to study motor control. So I studied motor control, but I also started to begin recognizing how it is that you conduct any motor task. You've got to generate signals, and signals are created through images. Much of our thinking has to do with the images that we create, the auditory responses that we create, and every thought you have is a physical event. Interestingly, how our patients believe about their treatment, what they think about us, those are physical events. In other words, this thing that we have contained in this, coconut up here is the thing creating the thoughts. And to the extent that this is the age of the brain. Remember, we had back in the 80s, we had the age of the disc, I think. We did the disc, and then the facet joint. Now we're truly into the age of the brain, where we're trying to crack the code on this nervous system, which is fascinating. But we need to understand this. When we understand the neuroscience behind this, we feel a little bit more empowered to intervene, because we can't not. Our success as clinicians in our space depends upon our ability to understand this to some degree. Doesn't mean we're diagnosticians. It just means we need to understand it. So the wave is coming, and we're really close to that because, and I'll try to frame that up, how it is that it's coming. Let's talk about the center of care. You've heard of it before. Remember the days when you were the provider, and some of us may remember, I don't, maybe probably Jerry does, when you were the authority. They would come to you, and they would do what you said. You go to your doctor, my doctor told me to do this, and so I just do it. That was probably one of those baby boomer generations or something, right? They would just listen to the authority. They listened to the authority, or even the generation prior to that. And then we as providers, or any provider in the space, used to go, hey, I'm the boss, do what I tell you, and I don't care if you don't do what I do, I don't care, I'm just going to tell you what to do. Well, of course, that didn't work. It didn't work, and the pendulum, like most things, swings in the other direction, so now we have this idea of patient-centered care. So the patient is the center. The patient is the center. Now, back to what patients want. Remember, patients expect caregivers to show that they actually care. Patients want providers to understand their whole issues, needs, life issues, ... Patients. It's about the patient. I have a question. What do providers want? I mean, what about us? Huh? We want to get paid a little bit more. Yeah? What else? We want full schedules. We want to be busy. We want to be recognized for our value. What else? Less stress. Yeah. We want to contribute in a way that's meaningful. We want to spend less time on documentation. Raise your hand if that matters to you. Got it? You see, we want to make a difference with someone who's equally engaged and passionate about getting better as we are with wanting them to get better. Does that make sense? In other words, we are part of this equation. And if it's patient-centered, we've been left out of that equation, essentially. So I just don't think patient-centered works. I just think it's a misnomer. And I think right now what's happening, especially in a lot of the hospital outcomes, you're trying to get providers to follow the script of what to do to be patient-centered. And I just think it's dumb. I just don't think you can tell people that. And I think we're missing the point. We're missing the point that if it's patient-centered, it's not provider-centered, and I have needs. I was at Combined Sections meeting with Jerry Durham, and we did this patient panel thing. We actually had 2 patients get up on stage and present at the Combined Sections meeting and they told their stories. And it was horrifying. They just kept bashing the provider because the provider didn't listen. They didn't hear my story. They didn't, And after a while I was going, have you ever tried to be a provider? I am not excusing some of the stories that they told, but it's not easy to do what we're doing. And really, we have to be mindful about how it is that we are equipping ourselves to participate in what should be a relationship-centered approach. It's not about you or me, it's what happens between us that matters. And that's a spatial delineation. I want what happens between us to matter. I've got me, you've got you. You've got your thing, I got my thing. We're going to come together, and are we going to work together to get the third thing? See the difference? It's subtle, but I think if we don't redefine the language, we're not going to get there. It's got to be relationship-centered. So, of course, there's a coolness that happens when we are relationship-centered. Education, sensitivity non-medical, respect for patients' needs and preferences. This is the stuff, the good stuff that gets to happen. Patient satisfaction improve, adherence to treatment plans, decrease overuse. A lot of it happens because we're focused on what happens when we put our combined efforts together. You ever been in a relationship where the other one didn't show up? Yes? No? What's that like? What does it feel like when you're in a relationship and the other person in the relationship doesn't show up? After a while, what do you feel? Yeah, betrayed and hurt. Especially our younger colleagues, and this is really important. Paul and I were talking about what happens when you get old. Like, I'm getting old. When you get old, huh? Oh, I mentioned old. Okay, so is me. I probably brought it up. But what happens when we get old, we have our younger colleagues coming into the company, and they don't know how to manage this. They just get, at some point, they feel like someone else is not showing up to their relationship, and what happens there? What gets to form? Resentment? Oh, this patient. And then what happens to your environment when that happens? That patient experience, is it great? No, it starts to suffer. So part of it is equipping our colleagues to manage this well. Identity. This is good because we were speaking to this earlier. Alignment. This is cool, especially when we talked about the millennials in that conversation earlier. If you take a look at your organization, oftentimes what we're trying to do is elicit behaviors. It's the same thing with our patients. We want certain behaviors because if they just did it, what would happen? It's like the commercial. Just do it. If they just did it, what would get to happen? Yeah, things would get better. Your mechanical system, if you stress it properly, will adapt. Your motor system will adapt if you teach it and practice. Well, if you just do your home exercises, things are going to get better most of the time. So we want behaviors. But oftentimes, have you ever noticed people who try to change behaviors by changing their environment? I'll give you an example. You ever known someone, or perhaps yourself, knowing that your behaviors you want to exercise, so you buy an exercise bike? You ever buy an exercise bike? Put it in the garage? I'm going to exercise. It's in the garage. There I am. I got an exercise bike. I'm going to exercise. She's laughing. So what happens to that exercise bike? It's a clothes hanger. I hear that every single time. It becomes a clothes hanger. No, it's a good story because you're trying to change behaviors with environment. It's a lower level. It's a lower level. Changing behaviors by changing the environment. Another one is a good one is buying a gym membership. I'm going to buy a gym membership. What gets to happen there? Well, I'm going to use it. No? Statistics show you don't do it. To change behaviors, you have to go above. So think of a top-down process. You have to begin teaching capabilities, and we do this well in the clinic. We teach people exercises. We teach people lifestyle in some instances. And that can, at some of them, may change behavior. However, the real juice comes when we start talking about beliefs. Beliefs and values. Beliefs and values are what drives most of our behaviors. Our ability to speak to the patient at a belief or value level is going to impact and influence their willingness to participate. And those language sets are very specific. More importantly is identity. If you speak to them at the identity level, then you're going to already begin to help understand their beliefs and values. So if you identify yourself as a millennial, or you hear the word millennial, which is an identity, right? I am a millennial, which is different than saying I was born in the period of the millennial generation. Feel the difference? It's like the difference between saying I'm a golfer versus I play golf. How many of you play golf? How many of you are golfers? Subtle difference. Because what's a golfer? You can picture a golfer. Can you picture a guy who plays golf? Do they look different? Yes. Subtle but powerful. Very powerful. So we get a chance to speak to patients at their identity level. When our speaker earlier started talking about the power of speaking to the millennials at their identity and what most importantly, their mission, which is the highest of all, is what you're doing in service of, you really get to connect a behavior with a purpose. Connecting a behavior with a purpose, which you'll hear this subtly in the popular press, the big why. You know, contributing to our team, doing this behavior because it impacts our team. That's the science, pretty much, of what he was speaking about earlier. And this is the logical levels of alignment. Robert Dilts came up with this. So this is a process of knowing that it's a top-down process, and you as yourself and your teams can determine whether you are here as a technical advisor for your clients, or are you here as the inspiration for your clients to move forward in their story. Who are you? Who is the physical therapist? Isn't that a cool question? Who is a physical therapist? Well, we have a joke in the office, right? Because in one of my colleagues in the education company, which was right next to the clinic, kind of goes, I'm going to go get some physical therapy. I'm going to go get some, because they have a bucket of it in there. I'm just going to go get some physical therapy, and I'm going to get it on me, because I need to go get some physical therapy. Like, there's some physical therapy over there, or you can go get some physical therapy over there, because physical therapy is physical therapy, right? It's like oatmeal. Oatmeal is good. It's good for you. Is all oatmeal the same? No, there's some variations of oatmeal. Back to relationship and identity. Are we physical therapists, or do we provide physical therapy? Go see your physical therapist, or go see your physical therapist is different than saying go get some physical therapy. Feel the difference? It's subtle but really important. Physical therapist is a relationship. Physical therapy is a commodity. Big difference. I'm trying to get us all, I mean, many people are trying to get this language out to us. Infuse this into your organizations. Create a relationship. Be the physical therapist. All right. Good doctors are defined not only by what a physician must know and do, but more importantly, by a profound sense of who a physician must be. Who are we as a profession? So the APTA years ago did a study and looked and did a brand guideline, so that really tried to do archetypes of and identify who the physical therapist was in the eyes of the consumer. And it came down to, we are known as a coach, teacher, and a rescuer or a warrior. And the two major archetypes for this are the sage hero. So we are sage heroes. Don't you feel like a sage hero sometimes? You know, really smart and at the same time helping somebody through a situation? Which is different than what a lot of people are just doing, is we can't procedure people. It just can't be about proceduring. We have to be more engaged in a way. So we build stronger relationships with our audience, and our tone, as I mentioned, is a sage hero. What we have to say has a purpose and a mission. So our tone is inspirational, passionate. It's authentic. Inspirational, motivational. Emotional, neutral will not suffice. Relies heavily on the voice of the consumer. It's imperative that our tone actively incorporates our patient's tone and move forward exhortation to patients to break free from the chains of limited range of motion. It is inspirational in tone to encourage patients to reach new heights. Inspirational. Inspire is not an emotionally neutral word. I mean, back to values and beliefs. Do you believe in an inspirational approach to your care, which requires a relationship? So, from a proceduralist to just doing something to somebody, to more of a manager or guide, which is what Rick was talking about. He was saying, guess what? We get to be primary care for some of these people. If we're not relegated to doing the same old routine to people, we can't just procedure people better. We have to guide them better, which means we need a whole new set of tools. From an expert to a mentor or a coach. Yeah, I know a lot of stuff, but it doesn't matter how much I know unless you're willing to follow me. It's cool. I'm smart. Well, I'm only as smart and valuable as your willingness to follow me through it. Cure to a healer. Expert-centered care to relationship-centered care. Biomedical approach, biopsychosocial approach, and evidence-based towards outcomes, value-based, which includes and incorporates evidence. So either way, you're going to have to produce greater outcomes. Who will be demanding greater outcomes? We know this. It's consumers, insurance companies, employers, providers, just that list goes on. The physical therapist is still the ideal person in the healthcare system to guide patients to better health. No one, oh, by the way, just as another question for you. This is the participatory part of it. At what time in your life are you most likely to consider change? When you're feeling good? Or when you're in pain? When you're in pain. How many people come to us saying, hey, John, I'm feeling great? They're usually saying I'm in some sort of pain. What do we do with that? Where's our opportunity in that? It's difficult to get people to change if they're doing well, because it's working. But if all of a sudden there's pain, we have an opportunity. We should be capitalizing on that. We have the most time with patients. Really. We have the most one-on-one time with our patients. We have the potential for the best relationship with patients, especially as we develop our skills in this sense. People come to us in pain. It's a perfect time to consider change. Healing. This is an opportunity to really bring some neuroscience into an archetypal story. If you want healing to happen, and you could go to the jungle of South America, and you could walk through the different villages and gain someone's experience for what happened. If someone has an affliction, let's say I have a thing on my thing, and it's bothering me, so I want to get my thing looked at. I could go to the village, because my intention is that I need some help. I'm going to go to the person who's been designated the healer. So I am going to form a relationship with the shaman or the medicine man. And then at some point in this experience, I am going to have a ritual performed to me. Something. I'm going to get hit in the head with a rattle. I'm going to get some bone dust blown on me. Something is going to happen. And we know that in the context of that, pretty incredible results can happen. I mean, knowing that this is an archetype of what happens, because, in Western medicine, we have some fairly sophisticated rituals. And if you think about it, we have a lot of people lining up at the door for help. But what's missing in Western medicine? Relationship. Who knows their primary care provider anymore? Because as Rick said, everybody changes over. In fact, part of our discussion at the staff meeting that I missed today, because I'm here, is my partners decided that we're going to pay an increase in the premiums to keep our current plan so that we can keep the relationship with our providers. So we're going to pay more as a company to do that. Ouch. Because they're trying to churn us. It just came so apparent to me today. So anyway, relationship matters. So the research on relationship is extensive. This is a randomized controlled trial that took a look at placebo acupuncture. They took 3 groups over 3 weeks. One group got warm, empathetic interaction, neutral interaction, or weightless control. They actually did provider training so that the providers were taught how to be empathetic. 20 hours of provider training, how to be empathetic, and how to explore the different variables. They videotaped them, and the results were this. Those on the wait list got a little bit better. And by the way, and I left this out for a second, this was placebo acupuncture. This wasn't real acupuncture, it was placebo. So what they found is that people got better. But they got more better if they were an augmented group, where the engagement in the interaction was more robust. The results of that, if you take a look at all the different providers, there's 4 different providers, everyone who did well in providing an augmented engagement got better outcomes, especially provider A, who is apparently a very good actor. So the results of this is the quality of the patient-practitioner interaction accounts for the significant difference between the groups and the placebo response. It's a big deal. It accounts for a certain percentage. So the intention, a patient's desire to ease suffering and do something about it, creates an expectation in the brain. The activation of the chemical processes that optimize pain signal processes in relationship. This is what relationship does. It's a neurochemical. Engagement is a neurochemistry of safety, warmth, feeling like you belong, all of those things that we know that we all want. When you experience that with a healthcare provider, your results get better. It primes the nervous system for a result. And the ritual. We have all kinds of rituals in physical therapy, right? We do stuff to people Sometimes we do that, sometimes we do that, or sometimes we do an exercise that does that. Those are important. There's efficacy to all of the stuff that we do, and there's not as much efficacy to other things. There's always efficacy in what would be considered the ritual response, the ritual effect. Mechanical, chemical, psychosomatic. That's the kind of stuff that we provide. We know, and I remember this in Belowski's work, he does a great job. He stood up at CSM one year and he just said, you know, this is what happens when you do that manipulation. You're basically sending a big information blast to the nervous system. The information system gets it, and these are the different levels. A lot of this can be explained in the pain modulatory and what happens specifically in those centers of the brain that are address fear. Or the fact that you're expecting it to make a difference, and the suggestive language that you use can make a difference. So it's a big, big deal with a lot of implications. So what creates outcomes? All of these things, right? All of this can be a balancing act that ultimately creates outcomes. The therapist techniques, and the relationships. How much energy do we currently spend on developing skills that determine success? Well, we spend a lot of time on the techniques, the manual techniques and all the things we learn as physical therapists, but how much time are we spending on relationship? Therapist techniques. See, I got my buttons wrong. You ever do that? Just get your wrong button? Okay. So a new emphasis on relationship skills. But to get good at this takes practice. I mean, it's like anything. You climb into it, you get some specific guidance, you determine the knowledge, the skills, the mastery, and then you practice it. And a proactive, and Paul and I were talking about this too, about this idea of personal development. It's almost like we need to bring people into a mature understanding of who they are in the context of their profession, but also in the context of a relationship with their patients. So professional growth, personal growth is a bold place to be for an entire company. And then financial growth. So we have an active process of personal growth. And the science of interpersonal neurobiology is cool insofar that we have to recognize that people respond to their internal maps of reality, not to reality itself. And this is a very aggressive clinical thing that would take really some time for me to explain well, but I'll do the best I can. Our internal maps are formed through our language and sensory representation system as a result of our individual life. But as you know, if I had a map of Seattle, and the very nice guy up here at their hotel gave me a nice map of the town here in Bellevue, and I looked at it and I said, well, that's kind of cool, but I know that it's a map. It's not actually the territory. The territory is out there in the streets. But we work from maps, and sometimes our map is not accurate to the territory. That doesn't prevent us from moving forward. The map is not the territory, so our mental models of reality, rather than reality itself, determines how we respond to the world and act. Successful providers are able to understand their own maps and their patients' maps. So when I'm able to help a patient understand what happens, and if they believe that their back pain is a result of this, and if I can do a good job of using their beliefs to address what they think is wrong, but at the same time fill in their map, I may be able to get their beliefs to shift about what actually is causing the pain. Big deal. Because you know what happens when you start crossing beliefs or coming at odds with a patient's beliefs? What happens? Who wins? Yeah, you lose the patient. It's a big deal. And we have a lot of pride in what we know. Pride's not going to help you. What's going to help you is to be an expert at reading maps, understanding their maps, and moving forward. Determine how to help the patient build out their own map. That's a process. So what do you see? It's the same thing we mentioned earlier about what the beliefs that we have about our patients, the beliefs that we have about our patients, but also the beliefs when our colleague said millennials. As soon as you said millennials, some people already had some preconceived notions, right? That's what our brains do. They create preconceived notions. When you see a chronic pain patient on your schedule, on your Medicaid plan from your chronic pain doctor, what's already going through your mind? Like your day just got better, right? Yeah, excellent. I love that patient. Those guys are into it. All right, because what happens? Well, you have experience, beliefs, assessments, judgments, and intentions. So you have already framed up your own map of the story. You're going to proceed either with that map or you're going to pause, bring some mindfulness, and clear the deck to determine how you're going to best interact with somebody. So what are common beliefs that you have about patients that may limit your ability to connect? Just label, get one, so Jim doesn't get me the hook off stage. What's a common belief that you or your colleagues might have that may prevent you from connecting, or your colleagues from connecting with a customer? Yeah, malingerer. Classic, right? Oh, they're just faking it. Or something. Yeah, that's pretty classic. So, what expectations, beliefs, judgments, and intentions does your patient have about their experience with you? I already had physical therapy before. I had some already. I tasted it, I went there, I got some, they put it on me, and I was like, man, this is physical therapy? This doesn't work. I talk with many physicians, and they say, you know what, it's hard to get people to go to physical therapists. I said, why? Well, they say they already had physical therapy. Okay, so they already had some oatmeal. So they don't like oatmeal, so they don't want any more oatmeal. Well, it's not all the same. So they often, how do you deal with those when it happens? There's some really tricky ways to do that, some important ways. And so you got these two things coming together about how these two beliefs can come together and possibly conflict with one another. And this conflict between a patient and provider can really add a lot of tension. It takes some of the energy, excitement out of the possibility and the process. So recognize that the patient comes to the engagement with all of these things. The provider has the same things. Two people with their own unique maps and stories come together. I see you. I got all my stuff, you got all your stuff. Now what are we going to do? Hopefully, knowing that you each have unique worldviews, you're going to come together in a therapeutic alliance, which is a relationship that has an agreement on the goals and tasks in some context of an unconditional positive regard. Can you hold an unconditional positive regard for your patients? Well, it depends on the day, I think, right? Some I can, some are harder than others. It's an exercise. It's a skill. I don't have resistant patients. I don't have patients that I don't like. Not even about like, that I can't work with. I simply don't have resistant patients. There's some patients I can't help, but that's totally different than feeling the challenge of resistance. I don't look at my schedule and go, it doesn't happen. Because of the way that you frame the experience. And often this results in better business success. Adherence, motivation, decreased cancellations, all those cool things that you want in your KPIs and what have you, that's what it results in. Now, there are times when it doesn't work. If you don't get that in place, then you have suboptimal outcomes. So why are patients non-compliant? I love this. Isn't that awesome? Yeah, it's fantastic. And take a look at a couple of things. How is this lady communicating? Is she communicating something? There's something I teach in this course, and it's really important. You are always communicating. You are never not communicating. She smiles. Susan goes, I know. Truly. Now, and how much of what we communicate is actually the spoken word that we have? Not that much. There's as much in the inflection of the tone that we use. And our speaker earlier, he's not here, right? I forget his first name. What's his first name? Jabez? Yeah, what a great speaker, right? Why? What did he do well? Fluctuation of his tone. I could just listen to the guy. He could be going, rah, 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 not saying anything. It would still be kind of cool. Don't you think? So, there's a way to do that. How can you be that? How would you implement that skill? Not unlike you would have the skill of being able to line up that joint perfectly, right? Perfectly line it up, end range, here, 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 3 dimensionals. And would you not want to also be able to line up the communication skill, the language set that would initiate a result that you desired? To prime the environment for a better outcome? I would think so. So, most common reasons for noncompliance: perceived barriers higher than perceived risks. Lack of rapport, relationship, trust. Why should I do this thing when this guy he doesn't? I just do the same thing. Why would I have to pay that copay? Why would I have to pay the cab to get there in order to do it? because the cost is high. Is the benefit that good? 5 minutes remaining. Thank you, Jim. Mismatch goals between patients and PT's treatment plan. This is the lack of alignment. Do you ever have expectations that the patient just says, doesn't even buy into? Yeah, it doesn't work. Just don't try it. You'll feel failure, and failure is no fun for anybody. So no agreement nor connection between the goals and the therapist's treatment. Improper pacing of the treatment. So you want to set forth, you want to keep moving it forward. And all of a sudden that doesn't work for the patients. We talked about this CJR, right? This is going to be difficult. We got to get results in 3 weeks after a total knee replacement. You know, what happens if they're a patient that goes slower? They just don't tolerate the pace. How do we navigate that? How do we set an expectation that we're going to have to dial up the intensity of something to get a result? These are challenging. Insufficient resources. There's a negative consequence of getting better. Ooh, this is your malingerer, Jerry, right? And, you know, we might reframe that whole idea of this, rather than being intentionally about not getting better, they may be ambivalent about getting better. Like, truly, there may be some positive reasons to not get better. Can I come to a place where I'd appreciate it? Maybe even work with it. Identify it clearly. This might be a conflict for you. What do you think? Yeah. All right, let's see what we can do to work with that. Which is different than judging them as, hey, you're not in this game. Psychosocial barriers. We talked about this. These are some of these things, and we're not psychologists, and I'm not proposing that we should be, but we need to recognize the red flags and the yellow flags and the blue flags and the orange flags. So aligning maps, big deal. Perceived, this is the idea of the patient comes in, and this is something we work on to help people understand that if we can help understand their map, what they think the problem is, their goals, what they think are the pathway to goals, the barriers to their goals and their resources, which is a well-framed outcome, if we can get that from them, we can work with it. And then what we get to do as the provider is have the exact same thing. And my hope at the end of the game is that my perceived problem is the same as what they perceive the problem is. But how do I know what they think the problem is? What do I have to do? I have to ask them. I ask every patient, what do you think the problem is? And let them tell me. I can work with that. And if I rush into it too inappropriately or with my own ideas too quickly, what do I miss? I miss the relationship. I miss what happens between the two. So if my goals are different than their goals, it doesn't work. If what I think is necessary for them to get done and what they think is necessary to get done, I'm out of alignment with them. It's not going to work well. So we've got to overcome all of those things. So these are the different skills that people can learn if they're so inclined to learn about this stuff. So at the conclusion, relationship-centered care creates a neurological foundation for better clinical and business success. Language and communication create an experience. The words that we use create an experience. Oh, he did a great job with Jabez. He did a great job with this clapping thing. You could feel, where are you? You could feel the nervous system get excited about approaching that goal, couldn't you? And you could feel the opposite. That's a physical event. An experience is a physical event. It's physical. You're a physical therapist, or most of you, if you are. Psychology and physiology are inseparable. Brain sciences is panning out with this stuff. Brain sciences. Pain sciences and brain sciences. This is the next wave of stuff. Relationship and empathy have a physical consequence. Providers can develop skills to optimize physiology for desired outcome, and organizations that align with the mission values that represent the desired relationship will thrive in an evolving healthcare system. Okay, so if you want to learn more, email me or something like this. Jerry knows how to get a hold of me. Thank you very much. I appreciate the opportunity.
Great.